Ramki, you are muted.
Hi, everyone. My name is Ramki. Welcome to Weekend Wellness Series 18. For the past, I think, 9 weeks, we have different presenters every Saturday and Sunday giving us a wealth of knowledge. We'll be ending all these sessions hopefully by Father's Day. I do have some interesting presenters for the next couple of weeks. And today's presenter, Dr. Parth Sardi. He is a good friend and an associate professor at VCU. And he also works part-time with Dr. Surya Dakar. And the topic for today is making informed treatment decisions with your dentist. Partha, go ahead and you can proceed from there. You can start. Yep, there you go.
All right.
Thanks, Partha.
Thank you, Ramki. Thank you very much. And thank you, everyone, for spending probably an hour with me on this wonderful Sunday afternoon. I just want to speak a little bit about when you are in a dentist office and you're going to and you may go to a dentist office for different reasons. And I just wanted to give a broad overview of what is it that you need to know and what are the right questions to ask and should be your expectations when a dentist proposes a treatment. I always believe treatment plan and treatment decisions and options are basically a mutual agreement between the dentist and the the patient should be involved in making those decisions. Now, the dentist can provide options, but the patient should be the one who is driving the decisions. And I hope this presentation, so there are different, dentistry is big and wide, with a lot of specialties. So I'm going to touch a few topics that I feel patients need more information based on my own experience. So hopefully this is useful information. And if you guys have any questions at any point of time, feel free to ask and I'll be more than happy to answer them. Before we get onto this, it's not meant to disappoint or make people feel that, oh, this is basic stuff, but basic understanding of oral cavity and the mouth and the teeth are important, not just in terms of a general knowledge, but specifically as it applies to treatment, as we're going to discuss today. So my first few slides are going to be the ABCs of teeth, and from a structural perspective, from a functional perspective, things that you need to know as a patient. Okay, so let's get started. Again, as I said, a few terms. So we as dentists, more and more of late, we are focusing, or we are getting more expectations from the patients are higher as it relates to aesthetics and improving the smile of a patient. So the patients are nowadays coming to us saying that, okay, can you work on our smile? I just need to be able to smile better. And one of the teeth is not working or not looking good, or whatever it may be. But definitely the aesthetic perception of patients have increased a lot, and it's possible, it's mainly due to the societal awareness. And as a patient, I think you need to know a few things. The face by nature is symmetrical. The right side is almost identical to the left side, and there is a midline. So the teeth on the right side are similar, very closely symmetrical to the other side. So the right and left sides are mirror images of each other, if you want to say that. So you need to know some terms. I mean, we call these teeth by certain designations, and the tooth that is right in the middle is called a central incisor. The tooth right next to it, okay, as you go away from midline, the second tooth away from the midline is called the lateral incisor. Then it is called the canine, because a lot of times people say, especially in these in the past few months during the COVID, and now when we are doing these tele-dentistry visits, the patients are telling my canine is hurting, but in fact they're completely wrong in the tooth that they are having the problem with. So it's important, at least, I would not expect any of you to know this before COVID, but now with increase in tele-dentistry and telemedicine, I think it's important to get a handle on all these simple nomenclatures. It's not too hard, but it conveys a lot of information to a dentist. So canines are the third tooth, and then there are two premolars by nature. if you have undergone braces in your childhood, you may have extracted one on each of the four sides or only on the top. So the number of premolars can change, but that is very unique to every person. So those are the teeth that you need to be carried about, and anything behind that is the molars. And there are two sets of teeth. Basically, we all know there are, a baby teeth and an adult teeth. There are 20 teeth in kids and 28 to 32 teeth in adult, and that depends upon whether you have a wisdom tooth or not. So if you don't have wisdom tooth on each of the four quadrants, then you're going to have 28. If you have wisdom tooth on all four quadrants, then you're going to have 32. The difference between an adult teeth and a baby tooth, and again, this is especially important in the light of a lot of our friends and families. We are first generation. So when we see kids growing up and they have baby teeth and then the adult teeth starting to show through, I've seen a lot of concerns. So I just thought this was an important information. So the basic difference between a baby teeth and adult teeth is that adult teeth are much bigger. They occupy more space. And that is important because of the potential need for braces that we will discuss later on. This is an important slide, both because I've been working in VCU for more than 8 years, and I've been working before that as a dentist for probably around 20 years now. The most common misconception that people have about teeth is that, oh, teeth is just dead, and it is nothing. It doesn't hurt, so that equals to, in people's mind, it is a dead tissue, but it is not. And the way I explain to my patients is that teeth is unique because it is living both on the inside and on the outside. And this is an example of a tooth, the front tooth, the central incisor, that a patient had fractured because of trauma. And the center of the tooth is red, and the red is the living part, which we call a pulp. And we will discuss that in the next slide. So it is living on the inside. So the pulp is the heart of the tooth. And then it is covered by a very good insulating layer outside. And then it is also living on the outside, because this is where the tooth is attached to the bone. So the tooth is attached to the bone by ligaments. And this ligament is again a living thing. So tooth is not only living on the inside, it also lives by the outside. And this, by being alive on both the inside and the outside, it can also die from within and from without. Meaning, if you there can be diseases of the pulp here, or there can be disease of the gum disease that's going to affect the red part. So red equals vitality or livingness. So here it is inside the tooth, it's outside the tooth. And this can happen due to a variety of reasons. Trauma, injury during when a baseball hits, or when you just bump your head against a wall or something, this can tip and it can result in this exposure. It can also happen in a dentist's office when they are working on a cavity. It can have minute exposure, and that can result in infection. Mouth is it's not a sterile environment. It's not meant to be sterile. It can be clean, but clean does not mean sterile. Sterile means no living organisms, no bacteria, no germs. But in order for us to be healthy, we need to have germs, and in the mouth is no exception. And there are millions and millions, billions of bacteria in the mouth, and we need them too. It's a part of symbiotic relationship. So whenever the pulp or the living part of the tooth exposed to saliva, it immediately gets contaminated with bacteria. So a barrier for protection is breached, just like how when you have an intact skin, you're not having any infection, but then once you have a little cut, then it starts getting infected, and that's when you start putting antibiotics on top, topical antibiotics. The same thing with the tooth. This is the inside, that is inside of the tooth that is protected, and it's protected by this layers here. And once that layers are breached and this is exposed, then infection is bound to happen. Okay, so those are the things that I want you to guess, just to get a sense of how teeth are arranged and shaped. And to me, the most important tissue as a dentist is enamel. Okay, and enamel is just a wonderful natural tissue because it is the hardest natural material known to man. And enamel covers almost all teeth. There are some diseases where enamel is not formed, but otherwise, enamel is always formed on all teeth. The quality can be different, the quantity can be different in different teeth. And it is not very thin. It is 3/10 of a millimeter to 1.5 to 2 millimeters at most. So that is the width, that is the thickness of enamel that we are all blessed with. And I just wanted you to see this. This is just a, you take a tooth, you take a tooth like that and then cut it and then view it from the side. Okay, that is what we are seeing here. And this outside, almost like a translucent zone, that is called the enamel. The inner opaque whitish layer, that is called the dentin, and the black is called the pulp. And the pulp is the what we saw, the red living tissue. So this is the heart of the tissue, okay, that is protected by a thick layer of dentin and a thin layer of enamel. That's all the enamel we got. We are not going to have regeneration of enamel. When you fall and break your bone, you're going to regenerate. You heal from fractures. You heal after accidents. Even if you have multiple fractures, your bone is capable of healing. If you have a cut in your skin, you can heal really well, not a problem. But the same is not true for the teeth. The enamel, once it's broken, it's chipped, it's gone for good. It's not going to come back. And at present, we don't have the science advanced enough for the regeneration to happen. Okay, the research is actively being done, but it's not there yet. So it's going to take a long time for us to be able to generate enamel outside the mouth. So the enamel is not sensitive, meaning as long as the enamel is there, you're not going to feel a thing. And that is the reason. And again, a lot of us don't have an appreciation of enamel and what it does. For some material, as an engineer or anybody, from just with experience, if you think you have a millimeter of tissue, millimeter of thickness of any material, that lets you eat anything from frozen ice cream to hot coffee and everything in between without being able to transmit that sensation. There cannot be any better thermal insulator possible. And it is it's paramount, both from a patient's perspective and from a dentist's perspective, to protect as much enamel as we can. Okay, that is my guiding principle in my treatment for my patients, is to preserve as much enamel as possible, knowing that enamel we cannot grow back. So that is the enamel. The second part, the second component of a tooth is called the dentin. Okay, so the dentin, again, these are terms that I want you all to be comfortable when the doctor explains, when the dentist explains to you, when you're in the chair and they're taking these x-rays and they're showing it to you, you should be able to be comfortable with it. Now, you can still ask questions. I'm not expecting any of you to be an expert. But at least you should be comfortable with the terms and with the understanding of what they're trying to say. So you would have probably seen a lot of these x-rays taken of yourself or your husband or your kids when you went to a dental office. So I hope you can see this top, which is much whiter. In an x-ray, everything is black and white and all shades of gray in between. So this is air. Air is black. And the more dense a material is, more inorganic a material is, the more white is going to be. The more metallic content it is, the more white is going to be. Okay, so so this is air, total darkness. And this is enamel here, which is a cap, natural cap. This is the pulp, because pulp is made of just arteries and vessels. So it is a soft tissue. It's almost like a skin. So it is on the inside. And the thin that separates between the enamel here and the pulp here is the dentin. And the dentin forms, so this part that here is the crown that you can see in the mouth. This part is the root, which is embedded in the bone. So this is the bone, and this dark space that you see around that is where the ligaments are. Remember we said the tooth is also alive from the outside. This is the tooth being alive from the inside. This is being alive from the outside. And all of these are richly innervated by blood vessels and nerves. So we'll talk about that. So this part is the dentin, which makes the bulk of the tissue. The difference from enamel and dentin is that the enamel is much harder than dentin. Dentin is almost similar in its physical properties to enamel, bone. But the important difference is it can sense. So once the enamel barrier is breached and the dentin is exposed, you're going to start feeling all the temperatures. You're going to feel the acids. You're going to feel when you eat something sweet or sugary, you're going to feel it. Okay, so as long as you have the enamel cap, you're not going to feel it. And this is one of the reasons why when you go to a dentist's office for a filling, they will say we need to numb you. And the reason for us providing that as a prerequisite is that you're comfortable with your dental appointments. Because once we start drilling and trying to fix the cavities, because we will be in dentin. And when we are in dentin, you're going to feel it because that's the nature of that tissue, because it can feel sensations. The next, the most important, not in a different way, the most important part of the tooth is the pulp. And I like to say it's a troublemaker, not from a dentist's perspective, but it's a troublemaker from a patient's perspective, because if without a pulp, you're not going to feel pain. Okay, in that sense, from a patient, it is trouble. It is the core of the tooth, as we talked about. It's rich in nerves, but biologically, it's also helpful for healing. Without something living, for anything to be categorized as living, it needs to have its blood supply, it needs to have its nerve supply, it needs to be able to regenerate. So pulp can regenerate, so that's why it's one of the hallmarks of being alive. The problem is here. The second half is where the problem. This is the good things. This is the bad thing. Because as I said, when somebody chips their teeth and the pulp is exposed, or when you're having a cavity and the dentin barrier is breached and the pulp is exposed, as we saw in the previous photo, then you're going to have only two options. And this is where pain is going to be a predominant symptom for the patient. And you will be having only two options. Either you have to go for a root canal treatment or you're going to go for an extraction. And we'll talk about that in a little bit. And I thought this was an important cartoon just for us to get a sense of what it is. So on the right side here, I don't want you to be scared. So this is just the tooth, okay? Intact tooth. This is the crown that you can see in the mouth. This is the root that is buried below the gum line. So this red thing is the gum line. This whole thing is the root. And when you section it, when you open it apart, you see the enamel cap that we talked about here. And you see the dentin here. And then the central part is the nerves, okay, the pulp. And the reason why you are able to feel once it crosses the dentin here is because these are almost like hollow tubes that go from the enamel to the pulp. It's almost like tunnels that go from the junction of the enamel and the dentin right here. And the one end of the tunnel is here, the other end of the tunnel is in the pulp. And there are cells and that can receive those sensations and that can feel it, okay? That's the reason why enamel is not sensitive and dentin is sensitive. Okay, because of these nerves here and because of these tunnel-like arrangement. This is just a unique type of tissue. Nowhere in the body we have these kinds of arrangement. It's a very complex tissue and it's a very, very complex, also organizationally, it's very complex too. It's very intricate, but this is the reason why you're feeling the pain. Even if the tunnel is opened at this part to the mouth, you're able to feel it because that tunnel, the other end of the tunnel is here, and it's just easy for the germs and the bacteria to just zip through it. And once the infection starts here, it is just transmitted through the nerve, through these two tunnels into the pulp. All right, so why is it important? I think this is an important slide. Again, this may be too detailed, but I tried to minimize it. I wanted for all of you to be able to see things. So on one side, This is the patient side. Okay, this is what the patients feel. This is what patients come to our office for. You can come for a normal visit, or you can have a mild pain, or you can have pain with cold that goes away, pain to cold, but that does not go away, or it is spontaneous pain that keeps you awake at night. So these are the 5 different, broadly speaking, any patient is going to fall in one of those 5 categories. So patient is on the top of the slide, okay? And then as we go through, I'll tell you what is happening. So normal, so this is the patient's subjective perception of what is happening. Okay, I hope that is clear. Now, this is what we expect to find in the mouth when we examine the patient. When we see a normal patient, we expect to see this. When a patient is saying, I have a mild pain, then we are expecting something like that. And you may not see a lot of difference here, but I will walk you through it, okay? But as you go along, you can see this part, I don't think anyone will have any concern that you can see the brown decay cavity, which is already formed, okay? So that kind of thing is bad, okay? This is just from the top. When you look at the tooth from the top, that's what you're going to see. And this is from the side, like, so when I see the tooth from the top, the second panel shows what I'm going to see from the top. But this third row is when I'm sectioning it, when I'm cutting it, and then trying to see where the decay is. And again, obviously, the third row is not possible to do in our clinic, okay? This is just experiments. We cannot section a tooth in our patients, okay? That is not okay. But this is just done for research purposes. And this also gives you a perspective of what is happening. When a dentist says, I think it'll be and the last row here is the treatment options. So the top row is what the patient comes to us with. The bottom row is what we as dentists provide to the patients. And in between is the clinical presentation as seen by the dentist, okay? So we go from here, symptoms, patient symptoms, to dentists providing treatment. So the sealants are on the left side. And normal is when the enamel is good, dentin is good, or if it is just the small decay that is just taking some amount of enamel off, then we suggest placing sealants, okay? Because sealants are it's almost like caulking. Enamel on the back teeth it's not a uniform, flat, smooth surface like how you have it on the phone. It is made up of ridges and grooves. It's almost like valleys and grooves and the rivers flowing in the depth of those valleys. And saliva is contaminated. So anywhere that the body can find the germs can find to shelter themselves from brushing, it's going to occupy that space. And the way cavities are created is the germs eat what is left over in the mouth after we eat, and they digest that and make acids. And the acids, this is an inorganic, when you see the enamel and dentin, they are like an eggshell. And I know a lot of you would have done this with your kids as a science experiment. When you dip your egg in a vinegar, which is an acid, it becomes soft. It becomes almost like a jello. It doesn't have a sharp, hard enamel shell. It doesn't crack open. It just becomes a spongy ball. And the reason why that happens is because it dissolves the outer enamel layer, okay? And it also changes the inside of the egg. So here, the same thing happens. The enamel being a crystalline material, it can be dissolved by the acids. And when we have germs and we have sugar, it's going to produce acids, and the acid is what is driving this issue. So on the bottom panel here, you can see when you do the cross section, so this is the pulp, the black thing is the pulp, and more closer and closer it goes to the pulp, you're going to need a root canal treatment. So on one end, the sealants are preventative therapy, or initial, where it does not cross the enamel barrier, we will do the sealants to prevent, to occupy all the nooks and corners of the teeth, so that we're not giving any space for bacteria, hiding place for bacteria. On the other hand, we have to go for a root canal treatment when it is that close to the pulp. You're going to be spontaneous pain. And as we talked about, there are only 2 things that's going to help you when you have spontaneous pain. One is a root canal treatment, and the other one is infection. So all of this pain is happening because of a cavitation caused by a bacteria. So I just thought, because I see a lot of patients who consider their teeth are dead, and I asked them, have you ever felt any sensitive in the past? And they all said, oh, I used to have some sensitivity, 6 months ago, and then it progressively became worse. And I used to ask them, like, so why do you, if you think it's dead, and why do you think you're sensitive? And then, sometimes you just don't connect the dots. And it is my responsibility as a provider to help patients understand what is going on in their own mouth so that they can choose the right treatment option that I will be presenting. So the myth is teeth are dead, but teeth are not. Teeth are still alive until we choose to make them die. And one of the ways in which tooth can technically be dead is a root canal treatment. Again, we are not making the tooth dead from outside. We are just taking the core of the tooth that is inside. The living part that is just within the pulp is taken out in a root canal treatment. So it's partial, removal of living tissue. And again, we talked about this. You need a root canal. You don't have a choice. If the pulp is exposed, you have to go for a root canal. Like we saw in these cases, these examples, where again, it can happen outside when you're playing playing volleyball or playing, cricket or baseball, or if you're in the general chair. And this is just all these things that you see here. They are not normal parts of your body. They are just ways that we try to isolate and drape our teeth so that we can have a clear environment. And in those, this is a cavity that was there on a patient. So as the cavity was being disinfected, since it was this close to the pulp got exposed. And if this happens, depends upon the degree of exposure and duration. So there are so many conditions that we as dentists need to take into account, but that's one situation where a root canal is indicated. So what do we do in root canal? We have to remove the infected or inflamed pulp. Essentially, that's what it is. Once the saliva touches this pulp, it is almost like a freeway for it. It is it's so hard for the germs. It takes so many years for the germs to dissolve the enamel and then go through this whole thickness of dentin before it can reach the pulp. But once it reaches the pulp, it's going on autobahn at this point. Okay, so the infection really spreads fast through the pulp into the bone, and then it gets bad to worse. Okay, so we don't want to get there. So the process of root canal is, in simplest terms, is to just remove all the infected tissue from the pulp. And this is an example of how long the pulp is in one of the teeth, and we can take it as a whole in some situations where it is possible. Okay, and this is a very good representation to tell you how big the tissue itself is, the pulp itself is. And once we take the infected pulp tissue out, then we will fill it up with something that is inert, because the body does not like empty spaces. It wants to be filled with something, okay? And we also don't want any space for re-entry for germs. So we always want to fill it up with an inert material. And it's going to look something like this. So this is a tooth that was having by now, I hope you're all able to interpret this. So this central dark thing is the pulp. And this cavity, this huge shadow that you see, that is the cavity. And the cavity is eaten through the whole thickness of enamel and the dentin, and it is approaching the pulp. Okay. And when you do the root canal, you take all the infected tissue out, and then you insert an inert material. And the inert material intentionally chosen to be white on an X-ray, because it is made of a metal. It has metal components to it. That's the reason why it is white. So whenever you see your own X-ray, when you go to a dentist's office, or when a dentist is explaining something about the root canal, it should be easier to follow. You should be able to distinguish between a tooth that does not receive root canal treatment, which is going to be black, to a tooth that has been root canal treated, is usually filled with a white material. Okay, so that is your root canal treatment. And once the root canal treatment, if it is done well, patients are completely relieved of symptoms, they get to keep the tooth, and everything is good from that point on. And this is an example of a metal filling from the past, a silver filling, as you can remember. It shows really, really white. So this is the white part of X-ray. This is the dark, is the air. And everything is in between these two: enamel, dentin, pulp, any fillings, all of that is going to fall between these two extremes: metal filling on one side and pulp or air on the other side. Okay. All right. So root canal treatments are usually done in a single appointment. Sometimes it can go into a 2 appointment if you have some specific complications, but most of the time it's done as a single appointment. And it's usually done by a specialist. Especially if it is a back teeth, both the top and the bottom. They have better tools and they work with the high magnification microscopes that lends. I always refer my patients for back teeth and root canal treatments to an endodontist because the patients are better served. I may attempt, it's not like I have not learned it, but even if I have learned it, a patient is better served long-term if he or she receives care from a specialist. And this I thought was, again, an interesting perspective for you to appreciate. This is just a zoomed up version of this slide in this picture here. And I want you to understand, this is the whole living tissue that you can see. And I don't know how many of you have ever experienced dental pain. And this is the thing, that is all there is. And just to give you a perspective of how big it is when we do root canals, it is almost the size of a paperclip at the top, where it is the widest. And then it narrows down to almost a point towards the end of the root canal, okay? And it is as long as a guy's fingernail. I intentionally said guys because if I say anybody's fingernail, I'll maybe way off. But it is not too big. So one of the things I now appreciate more is the complexity. Ridiculously compacted, concentrated nerves present in one small. It is just unbelievable that such a small amount of tissue can cause so much pain in our patients. That is just a state. So hopefully you would have understood a little bit more about root canal. And I wanted to address this advantages of root canal. Okay, we know it works. The patients get to keep the tooth. Again, as I said, usually done by a specialist. Whenever any tooth requires a root canal, I always tell my patients it's a two-step process. Root canal is the first step, and then you have to have a crown on top of it. And the reason why we need a crown is because nothing is as strong as enamel and dentin. So when we do a root canal, because we have a cavity, and the cavity means that portion of the tooth is lost, and we need something to replace that, and then nothing is going to hold everything together as a crown. So if you're investing in a root canal, it makes sense for you to be thinking about, or before you make a decision on a root canal, you should always be thinking about a crown. And most of the times the misunderstanding or the frustration between dentists and patients is that I never knew that I need to go for a crown. And the dentist may have told it, may not have told it, but this is just for you as somebody who is receiving dental care to know. It's always in your own good interest to get a crown on a root canal treated tooth. There are some exceptions where you can get away with no crown, but for the most part, you need a crown on a root canal treated tooth. Otherwise, your tooth is going to fracture, may not fracture 1 year, but it's going to fracture in 5 to 7 years, most likely. In the scientific evidence, there is enough scientific evidence for us to make that claim. And we have treated millions and millions of people with root canals. It's a safe procedure, it's effective, it's predictable. Okay, and the reason why I say this is in the next slide. It is an expensive procedure. Again, as I said, it's important for you to. One of the main deterrents for patients opting for a root canal treatment is because it's expensive, because it's done by a specialist. So, and again, you need to go for a crown also. So when you take the fee for root canal itself and then a crown, it is a significant amount, and that is usually the most important uh, factor that patients can't afford. Okay, and I see this all the time. I just wanted to make it make it known to people here at least. And this is how since I'm in a private practice, which is a lot of populations, parents from India, or even patients from India, they are. There's a tendency, and again, I was like that when I was in India, but there is always this tendency to get things done before they come to US. Whether it is us or our parents, whoever it may be, we try to get as much things done in the dentist office in India before we come here. The problem is, I can show we are seeing so many cases where they have done root canals, which was not done right, crowns which doesn't fit right, cavities, crowns placed on teeth, root canals done on teeth that should not have been done a root canal on. Treatment planning was wrong, execution was wrong, patients were not informed, and it's almost like a rip-off where teeth that does not require a root canal received dentists there did root canals on treatment on teeth that didn't need a root canal. It was like 5 or 6 teeth that was done root canal, and crowns were done within 2 weeks, because that's the window of time that we all have when we go to India, come back. And this happens with Mexico, this happens with Eastern European countries. So it is not only an Indian problem, but this is a global problem. And the reason is because obviously, and I understand this, I understand the motivation why we seek to do the dental care in India, because dental care is expensive in the US. There's no denying that. But looking at all the failures that's happening, and once a root canal is done, to retreat is going to be more expensive even by a specialist. The specialist is going to charge more. And it is probably not a good idea to go for extensive elaborate treatments in a rush. If you are not doing it as a regular 6-month or once a year appointment to a dentist, just because you're coming to US, if you rush through expensive procedures, irreversible procedures, and if the dentist says, okay, I want to do root canals on 5 teeth and crowns on 5 teeth, and I've seen all, and it's a rip-off. You are paying more money for treatment that was not required, and it is still going to fail. Compared to the only reason why it is not, I'm not saying that all the dentists here are good. The reason why people think twice before proposing something is mainly because we are held accountable by our boards, and patients can report to the boards directly without any. There is a means to address grievances from a normal public, which doesn't exist. The social contractual obligation from a professional in India is much less, compared to here. So as you all know, in all these different fields, we are all held accountable. So it is a good idea to think twice before you go for a full set of root canals, crowns, everything in India in a rush, because there is no way a lab can fabricate good crowns in a rush. And we don't follow the standard of care. The standard of care is also different. I'm not saying there are every dentist in India is bad, but you need to know who you're going to, which not a lot of us know beforehand. So Ramki, if you can let me know when to stop, or I can stop whenever, and then I can answer questions.
Is there anything else that you're looking for? You're almost done with your presentation?
I'm done whenever. Okay. I'm fine with. I'm fine.
I think we can go with question and answers part. Yeah. Thank you once again for excellent information. Sure. I think you will have some
this
questions.
Presentation has got more. This slide show, the PowerPoint has got more slides. I didn't have time to go through the whole thing.
Okay, sounds
but
good.
I will send it to you, and you can share that.
Sure, thank you.
And so, if anybody has any questions, they can definitely ask.
Okay, excellent. Actually, great information, Partha. So before I could start with the question session. I think Nagu already has a question. Is anybody going to ask the first question, or I can go with Nagu's question?
Yeah, Lata has a question too, but I'll go. I'll ask my first question.
Sounds good.
Partha.
Perfect.
You said for the root canal, you take out the pulp and put the inert material, right?
Correct.
But you also said the pulp is regenerating and self-healing material because it's a tissue, so it will grow back.
Well, okay. Continue your question. Yeah.
So at that point, the inert material is going to block that, right?
The natural growth.
Okay, that's a good question. It's a very subtle question. It's a profound question. So let me answer it this way. So when we say healing, your enamel, your pulp, as I said, it's like a tunnel. One end of the tunnel is in the pulp, right? The other end of the tunnel stops where the enamel starts, correct?
Yeah.
Okay. So when we say the pulp can have healing properties, what we say is when you have a small cavity, when the enamel is breached and the dentin is getting infected, that signal is transmitted through the tunnel to the pulp, and what the pulp does is, okay, there is something, invasion is coming, some signals are coming which I'm not supposed to receive. So in response, what the pulp does is it fortifies itself. It produces a layer of a dentin, which is slightly different in composition and texture, but what it is actually doing is producing one more layer of dentin as a backup. And then so that is what is healing. Healing is not in terms of complete regeneration.
Okay.
It can
so the inert material will stay and it is just like a fortified tooth.
It fortifies so what is it? It's feeling things, it is sensing things that it's not supposed to sense. So it's actually putting one barrier of dentin just to that spot so that it doesn't feel it.
Okay.
So it is not a true regeneration in a sense that where organs can grow back to its original size. If you take a liver, for example, and you can just take half the liver as a transplant, and I can still function with half the liver because the remainder of the liver will still grow back. Okay, that is true regeneration. If I break my bone will grow back. Okay, that is regeneration. But the way we define healing, we just say healing because even when you get a cut, you get a scar, that we say is healing, right, on a skin. Mm-hmm. So healing is different from regeneration.
Okay. Okay, thanks.
And Lata has a question, Partha.
Mm-hmm. Yes.
Hi, Partha.
So one last thing I would like to say, Nagu, is that by doing root canal, you are not affecting the regenerative capacity. It's gone beyond the point of the tooth to respond normally.
Heal itself. Okay.
Yeah.
Okay, thanks.
Mm-hmm. Hi, Partha.
Hello.
My question is like when there is a cavity, the doctor suggests fillings, right?
Mm-hmm.
So what type of filling is good? Now I know earlier they used to do some kind of filling which looks blackish on the tooth.
Correct.
And I don't know whether it was mercury that was used then.
Mm-hmm.
And then the second one is like the later, I think they introduced or the whitish color
Correct.
of the filling, right? So I wanted to know more about both, and which is good to.
Yeah. So you're absolutely right. The older, when I was trained in the dental school in India, we used to do a lot of, we call it amalgam fillings, silver amalgam, or we call it silver fillings. The patients usually say it's a silver filling here. I have a silver filling because it's the color of a silver, it's grayish.
Okay.
And it has a component. So the way we, when a patient comes to our practice, we used to mix silver powder and mercury together because mercury has this unique capacity to react with a lot of different materials, and it reacts with alloys. So, and it forms a concrete mix. It's almost like a concrete. That's what is that is exactly a good analogy for what is happening in a silver filling, amalgam filling. So the cement is the mercury part of it, and then the bricks and the gravel and the stones are the alloy particles. Okay, now it reacts chemically and it sets up. Okay, the concern earlier was that, at least in India, when I was in the dental school, we used to handle mercury because we used to have a dropper, we used to drop it, and then we used to mix it with hand. And it's exposed. Mercury tends to volatilize, it tends to vaporize in normal, like Kapuramari. It can just, like camphor, it can just disappear, it can vaporize, volatilize.
Okay.
So it used to be a concern, and it is still a concern. And again, there is a global movement, and the internationally all countries have agreed. It's called a Minamata Convention in Tokyo. After there was a nuclear disaster happened, mercury was released into the sea and all of those things. So they wanted to remove mercury from human use as much as possible.
Mm-hmm.
And that has also been reflected in the dental field, where we are now trying to wean away from use of mercury in the dental practices.
Mm-hmm.
It served really well. Amalgam is one of the strongest materials that was ever made successfully to fill a cavity. I have amalgams in my mouth. I have colleagues who have been having amalgam for 30 years. It is amazingly strong. It serves really well. It does a good job. There was a lot of controversy whether it was harmful or not to patients.
Yeah.
And there is no study that has shown that it actually can cause problems. All the studies that have been done to show link between amalgam and autism, and amalgam and neuro deficits, and amalgam and Parkinson's, and amalgam meaning mercury and mercury from the mouth to Parkinson, mercury and cancers, and MLS, MS, all of those, neurological deficits and disorders. There is no real evidence to justify it, because what has happened is mercury exists in different forms. Mercury is really poisonous in a form where it is called organic mercury, where when you breathe mercury fumes and vapors, that is the most toxic form of mercury. When we have a liquid mercury and we are mixing it up with particle, and again in the US and now even in India, it is all mechanized now. Nobody's exposed themselves to mercury liquid. It's all in a canister, and it shakes and mix it up, and then we use it. So the amount of mercury that is being released and volatilizing from that pre-mixed thing is minimal. And the amount of mercury exposure is probably going to be in the patient. They have detected mercury in the urine of patients receiving amalgam fillings in the first 1 day or 1.5 days, because that's when the exposure is most. Once the mercury sits, it doesn't release the mercury. Once the amalgam sets, it doesn't constantly release mercury in a form that is organic, that is toxic. So mercury fillings are, even though they are safe, they are now being weaned off to new material called composites. And these resin composites are, advantages are, they are aesthetic, they are tooth colored, and they can actually bond to, you can actually have a chemical bond between the tooth and the filling. So they're also very good nowadays with advancements in science and polymers and the composite materials. They are very good, and I don't think you can go wrong with choosing composites for any reason. The only advice I would say is you don't have to replace and remove and replace your existing metal fillings to a composite filling if everything else about that filling and the tooth is fine. You don't have to prophylactic, you don't have to prevent, you don't have to worry about existing fillings.
Perfect. Thank you.
Thank you, Partha.
Sure.
Donald,
The next two questions are pretty much the same questions. Mr. Kruger and Arvind has a question.
Sure.
They have a question about implants, and Arvind also added a second part to the question. What's the best way to get second opinion before a patient makes his decision on implant?
Okay. So can I go through the PowerPoint because I have addressed it? I didn't think I was going to spend such a long time, but
There you go.
if you guys are free,
You
I can go through it.
Yeah, I think Arvind,
Oh,
go for it.
yes, Ramki. So Partha, my question is, if I want to make a decision, so I want to put a bridge or an implant, so my doctor says you have to make a decision and let's do that. How do I go about getting a second opinion? So how do I share all my medical records to some other dentist so that I can
medical records by law is your property. Okay, so
Right.
it is yours to own. Most of the offices, by goodwill, they would not charge for giving you a copy. You have right to access to your medical records.
Right.
Most of the offices are going to be okay with giving you a copy of your records, okay, for free, but they are allowed to charge you some money if they have to share. Okay,
Okay.
it is not like they cannot charge. They can charge, but most of them don't charge. Okay, so it is a prerogative of the dental office whether they want to charge you or not. Whatever they feel is appropriate to share, they charge for that document, either to send an email or print out or fax or do whatever, in whatever way they want. Most of the offices are pretty good about it. They would share. If you ask them, if you say, can you put it on a CD or can you send me to an email, they would do that. With regards to how to ask for a second opinion, you would just ask the second opinion the way you would any other way. I think if you know somebody who is a dentist, the best bet is talk to them and see what they say. If you have absolutely no idea, then you're going to be looking up. You're going to look up and word of mouth essentially. Who is your dentist, and you ask your friends and see if they know somebody who have underwent the same treatment. You can ask your friends to see if somebody has got an implant and they had an experience with that dentist, whether it was good or bad or ugly, and then you can make that move at that point of time.
Okay. My neighbor is a dentist, so I can ask him.
Yeah, sure. I wonder who he is.
Yeah.
Thank you.
Okay, perfect. Any other questions?
So, Ramki, a quick question. Do you,
Yes.
do I have some time or no?
You have.
I have?
I think
Okay.
people want to.
They can leave whenever they want, right?
Yeah.
Yeah?
Yeah.
Okay. So I will go with my presentation and then you
Yeah.
tell me when to stop, or
Yeah, let's finish off the braces part, Partha. I think a lot of us have kids and,
yeah. So
we're
braces-
definitely, I was looking for this actually.
Okay. So I'll address two things. One is braces, the other one is the implants, and then we'll finish.
Okay.
So when is the right time? This is again a common question I've seen in our patients that we see, friends and families. They are always concerned about their kids, which rightfully so. When is the right time is the common question. So it's important for all of us to understand that when somebody sees spaces in their baby teeth, it's normal. We all inherit. Baby teeth are supposed to be having some spaces. Okay, that is by nature. I don't want you to get freaked out when you see no spaces or when you see some crowding in the baby teeth. Okay, it's majority of our kids is going to have some space, some amount of spaces in between their teeth. And if you see spaces, it's normal, it's good. If you don't see spaces, but they are just like that, if it is spaces like this, that's good. Any space is good. If it is like this with no spaces, then it is okay. If it is crowded, it's not as good. Okay. But the good thing is, it is just a good indication for you to know, okay, does my kid need braces in the future? If the teeth are separated and you have spaces between the teeth, then the kid is less likely to need braces or not severe need for braces. Or the amount of correction needed is going to be mild compared to no space and lack of space. Okay. This is the other common thing that we see in kids, where we have the baby teeth still there, and then the permanent teeth or adult teeth are growing on the tongue. This is the lower tooth, okay? Lower teeth, and these are the two permanent teeth, and they're erupting on the inside. And a lot of parents are concerned, like, my kid has got like, so many teeth, it seems too crowded. And this is happening because, again, the area where the permanent teeth are erupting is normal. It is supposed to erupt more towards the inside, tongue side of it. That's the normal way of eruption. And when you see a situation like this, you don't have to be concerned. You can go to the dentist, get clarified, and they will check if these teeth are wiggly or not, because these two teeth are going to be replaced by these two guys. And as you can see, these are smaller, these are much bigger, and there is going to be some crowding, because this is a small art. This is meant for baby teeth, and you cannot fit a big in a small room. Okay, and that's going to be some problem. But we also need to understand that the kids are growing. So as they grow, the size of the teeth are fixed. It doesn't change. It doesn't become bigger in life. It can become smaller because of a lot of different reasons. But the tooth cannot be bigger than what it is erupting. Okay, so when you see a tooth that is this big, but then the arch is small or the jaw is small, we have to know that the jaw is going to change and become bigger and bigger as the kid grows, but the teeth is going to stay the same. So it helps in resolution of that crowding. Okay, so you don't have to be worried about spacing here. You don't have to be worried about tooth erupting like this here. And we probably have to either worry about whether this guy is staying there for longer than normal time, or it has to come out. That is the only decision. But if these guys are taken out or it falls on by itself, then these guys will move and occupy a bigger arc in a oval, like, so as the radius of curvature becomes bigger, so it's going to occupy a much bigger space. So there will be enough space for the permanent bigger teeth. When do we need braces? Again, I always say, patients are concerned, parents are concerned, 7, 8, 9, 10, and I look, every kid is going to be looking different. So I don't go with the chronological age. I go with what I see in the mouth, because every tooth has some timeline where it is going to erupt inside. My goal, my guiding principle in saying yes or no to a brace is this one. It's like, I want to have all the baby teeth gone and all of these replaced by an adult tooth. That is when I'm going to start braces. I'm not going to start braces anytime before that, because it is still maturing, developing. Sometimes there may be some transient crowding or movements of teeth that will spontaneously resolve as the eruption, as time goes on. And I don't want to be correcting things that was going to be corrected anyways by nature. So I want to wait for all problems to finalize, and I want all the teeth to assume their final positions. And then I'll decide whether it is right or wrong. And if it is not right, that's when I'm going to do it. I'm not going to be in a hurry to start braces. And the ideal time for braces is usually 11 to 13 in girls and 12 to 14, 15 in boys. And again, this doesn't mean, this is just an ideal time. There's always going to be the range can be bigger, smaller, but on average, this is a good time window. And that is because that's when they hit puberty and the body is growing, teeth movements are faster, everything goes faster. So if you do a treatment, in olden days, we used to do it in 2 steps. We used to do when the patients are still at 8 or 9, and then we'll do the second phase of treatment when they are 14 or 15. And it was just meant to, it's no longer being done. And I don't think, unless there are some specific circumstances where a localized braces is advocated, but not a full-fledged braces that you're used to seeing. And obviously there is no, with recent advances and our understanding of biology, there is no upper limit for braces. And again, when you see something like this in your kid, don't be scared. And when the doctor shows you something like this, don't be scared. All you need to know is each one of this is a tooth, is an adult tooth. So you should be able to see, if you count all these things, so don't be scared. These are all normal things. Ask your dentist to explain. They will be able to explain things to you in a way that you can understand. Okay, so this is how your teeth starts to grow from the bottom of your jaw. It starts forming and then goes and comes and occupies. As it grows, it moves this guy. That's when it starts to be wiggly, and then pushes it out, and then comes and occupies its space. So when you see X-rays like this that your doctor is going to advise you take, when before braces, I would always do this just to confirm that there is no more adult teeth waiting to come out. All right. So can adults get braces? Of course we can, but limitation is biology is slower. It's going to take longer. It's going to be difficult to attain perfect results. Important thing is you need to disclose things that are any medications. You need to have a good dialogue with your doctor showing that, okay, these are the medications I'm taking, because some of them may affect the way your teeth are going to move or not move. And based on that, you should be looking at limited braces or limited results. So it's a conversation that you need to have with your doctor. And again, there is a lot of options, like, because adults are, they're working, they're social in life, they don't want metal braces to show through. There are a bunch of these options. All of you are pretty much aware of these invisible braces. It's a snap-on transparent plastic thing that moves teeth. There are these braces that go on the tongue side of your teeth. Usually the braces are on the outside, like this guy that you can see. But because of increased demand for aesthetics, people are now developed systems where you can put these braces on the tongue side of it. And the mechanics are still the same. The biology is still the same. It is just a little, the physics is different. And the other advantage, another advancement in braces is this guy here. This is the tooth colored braces, just like how we talked about tooth colored filling materials. These are tooth colored braces, and it's almost invisible. Unless you see it from close quarters, it's almost, you cannot tell. Or they can probably see a little wire that goes through. That's the only thing they see, anybody can see. And in fact, one of my patients, I treated her with these kinds of braces here. And she is a US educated, born, brought up, she's from here. And she actually got married with the braces on because she was not through with her braces. And I said, do you want to get the braces off for your wedding? And she said, like, this is invisible. I know, it's okay. I'm fine. Just take the wires off. And that's the only thing I did. I removed these wires, and she had her own wedding. When she came back from the wedding, I put the wires on. We completed the treatment that way. So these are really effective aesthetic options that are not available 10 years ago, but now it is available. So a lot of our patients are, preferring these, adult patients especially, are preferring these kinds of options. So I just wanted you all to know that these things exist. Concerns, again, this is for all the kids or parents with kids who are thinking of braces or are already on braces. It's absolutely important to reinforce this. Oral hygiene is important. Brushing, flossing, using a water pick, cleaners, anything to keep your gums clean is absolutely paramount for the success of braces. You can see here, the gums have become enlarged, grown, overgrown, and it's occupying space that it's not supposed to. All of this used to be the tooth. Now, most of it is overgrown by the gums. And that is because of plaque, and plaque causes the gums it stimulates and irritates the gums, and the gums gets angry and it just grows. And this is it makes it more difficult. It's a positive cycle, more plaque, more gum inflammation, more swelling, more places for the plaque to hide. And the cycle goes on and on. So this is one important thing that every parent should be paying attention to if their kids are on braces. They should never get into this situation. Second thing is called the white spot lesions. And this is, again, the good thing about cavity and gum disease is that both of these are mediated by germs. And if you are able to keep germs under control by brushing, flossing, you can pretty much have your teeth throughout your life with no problems, with no cavities. Most of it are 95% of problems is caused by germs. And if you just have good brushing, flossing habits, you're going to be having your teeth, pristine condition for the rest of your life. Okay. So this is a white spot lesion. This is again, as I said, like, vinegar on eggshell, it makes it softer. That's what is happening here. And you can see all these white opaque areas, and those are all the places where the enamel is being dissolved. And when the braces come off, you can see all these white spots around where the braces were. And these are all early stages of cavities. And these are notoriously difficult to manage because these are aesthetically compromising. Nobody wants to laugh or smile with such, extremely white and dark brownish white things. And these are better prevented than treated because there's not a lot of good effective treatment for this. Or not cheap options. We need to go for veneers or something like that, which is going to be much more expensive. Prevention is always cheaper than cure in dentistry. Absolutely. It's also better, or cheaper. Things to remember, whenever you are on braces, kids are on braces, make sure that they are on, you can ask your doctor about a fluoride toothpaste. They will give you that. Prescription strength fluoride, mouthwash, fluoride mouthwash, more frequent cleaning visits. If you go once every 6 months, you may have to go once every 3 months because the kids are not able to, it's unreasonable to expect kids to have a meticulous oral hygiene with braces on. It's just challenging. Some kids are really good about it, OCD about it, but not everybody. You also need to tell your kids to wear retainers after the treatment is done, because if their treatment is done like this and then they don't wear retainers, they're going to have problems coming back because teeth tend to go back to how it was before braces. If it was crowded like this and with braces you do it this, teeth tend to go back like that, and the retainer is going to hold things in a way that it cannot go back. So the most common things I see in braces are two things. One is white spot. Oral hygiene is paramount. The second thing is wearing retainers. I will skip this part because this is not, I'll go with the implants. What should I know about dental implants? I just need a few minutes. I'm going to play this video because this is a good information and we'll.
So what exactly are dental implants? Dental implants are a different way of replacing lost teeth, as they are fixed in your jawbone, so they function more like a natural tooth. Implants can be used to replace a single tooth. They can replace several teeth to hold a fixed bridge, or they can be used to secure removable partial and full dentures. They can replace teeth lost to disease or teeth that may have been knocked out.
Okay, so that is the implant. That's just an introduction to implants. And then this video, I just edited these videos so that I cut all the things that are not required. I just wanted to make sure that.
Before deciding on dental implant treatment, your dentist will take a complete medical and dental evaluation and develop a plan. This is to ensure you do not have any health conditions that could make surgery inadvisable. In addition, the dentist will use a number of different diagnostic tools such as CT scans or dental x-rays, so your implants can be placed with precision and with minimal risk. The process for having dental implants involves two separate surgical procedures. The initial surgery is to place the implant post in the jawbone and is usually carried under a local anesthetic. An incision is made in the gum tissue before a hole is precisely created. The implant is placed into the hole and the gum is stitched shut. The site is left to heal so the implant post can integrate firmly with the jawbone. During this process, new bone cells will grow on and around the implant post, ensuring it cannot move and that it is strong enough to support a restoration. To assist healing, dental appliances should not be worn for the first few days after surgery, as it is important not to put pressure on the site. If you must use the appliance right away, it might be possible to adjust it so it does not touch the implant site, thus avoiding placing pressure on the implant. The second surgical procedure is shorter and takes place between 3 and 8 months later, at which stage the implant will be exposed and evaluated. This is a process to determine if the implant post has successfully locked into the jawbone. At this point, it may be necessary to make some is to create an opening in the gum to expose the implant and placing a post known as a healing cap. This is so a tooth can be attached that will extend above the gum line into the mouth. The cap is used to shape the gum tissue to give support to the crown or bridge. The final phase is to thread a metal sleeve known as an abutment into the implant, and this will be used to hold the crown, bridge, or denture firmly in position. At this stage, your final prosthesis can be constructed.
Okay. So those, I think those three bits of videos, I hope was, I know you all watched it for the first time and may not have, but I thought those three videos was very good in capturing the essence of what a dental implant treatment is. Again, they are excellent choices for replacing single teeth, multiple teeth, or the whole arch. One of the prerequisites is, you need to have a complete 360-degree bone support around an implant. So, and again, you cannot, and that's the reason why we would like to take cone beam CTs. Though there are CT scans of the jaw itself, and it's a little different kind of CT. It's called a CBCT, and that is going to tell us all the information that we need to precisely, because it's a very precise procedure. It has to be done. It's crudely, it is like screwing a screw on a wood, but it is much more, except that you're doing it in a living person with a nerve that supplies the half of your jaw, 2 millimeters away. So 2 millimeters. So it's a very precise procedure that needs to be carefully planned. So it involves significant time and money. Like it is the best option for replacing teeth. Absolutely. There are going to be some candidates who are not going to be a good few patients who may not be qualifying for dental implants, like smokers, for example, or people who got some specific bone problems, people who are on some medications, people who are diabetic. Not to say that they are people who have previously received radiation therapy for the head and neck. Any of these conditions are putting them at a risk. It is not that they cannot receive implants. It is just that the success rate of implants in those patients are not as high as somebody who is not any of those risk factors. Even though it is the best treatment for replacing teeth, it is a significant investment for a patient in terms of time and money. A clinician should be really thorough in their assessment. You cannot just, it is not like a filling where you can just go and get it done. It requires a lot of planning, which means that it's going to need more than a few visits from a patient's perspective. Because if the doctor says, I need to come you 2 times, it is for this reason. You need to provide all the information. They need to get all the information from you. And some of them may be direct information that they can get from the clinical, and they may take photographs to have a record of tissues to study when you're not there. They may ask you to they may take some extras in the office, or they may also they will definitely take, and this is becoming a standard of care, to take these CBCT images of your jaws prior to placing an implant. For somebody who has broken a tooth and that tooth is just way beyond filling or root canal or a crown, we will propose something called a socket preservation, where we extract that root that was still stuck inside the bone, and then we put some bone grafting material in there, artificial bone, and use that to bulk up the bone. Because as we said, the bone implants, the success of implant depends on a 360-degree support of bone. So it has to be placed in the middle of the bone. So it is important for you as a patient to know implant is not a slam dunk where you say, okay, I'm missing this tooth. I've heard that implants are good. I've seen, Smile Direct, or no, not Smile, the same day implant surgery places. If you go there, they will place an implant, but it is not going to be successful, because every patient is different. And that's why clinical exam and cone beam images are extremely important. Because some patients are going to need some kind of bone grafting surgery. Some patients are going to require gum surgeries. So it is a lot of different things. You just cannot drill an implant into the bone and expect it to work, or expect to look good and work. It's going to be a compromise if you just cut corners. And then, so this is before the implant placement. You need to go, if you need some additional bone grafting or bulk up the bone, or if the gums are not really healthy, you need to bulk up the gum tissue. You need to have those surgeries done before even you are ready for an implant. And then an implant surgery comes, and then you have to heal, let the bone, the implant heal for 3 to 6 months, and then you have to come back and for another procedure. Where they will take an impression, send it to the lab, and then they'll fabricate the crown, and then you'll have to get the crown. So it may take anywhere from 6 months to probably a year and a half, depending upon how many implants, what kind of compromise the patients have, and all of those things. So I don't want you all to, at least I don't want you to be surprised when the doctor says implant is going to take this long. And one of the common reasons why implants are really, really successful, 97%, 98% successful. But one of the main reasons why implants fail is because of people grinding their teeth at night. And it's becoming an epidemic now. A lot of people, and that is just the way we deal with stress. It's a coping mechanism built in our body to deal with stress, is just bite or grind our teeth or chew on our teeth, clench our teeth. And I can remember when we were young and we used to get hurt, our doctor used to put an injection or something. We used to look out and then clench our teeth. That's our way of not feeling pain somewhere else. We look away and then we clench our teeth, and then, that's our coping mechanism. But during nighttime, if we clench, we don't know that we are clenching, and then it is just aggravated. So implants fail when you don't wear a night guard. So I would strongly recommend anybody who is getting an implant, when you're planning for implant in your mind, just don't think of implant as one thing. Implant is basically exams and surgery, exams and cone beam CTs. And then you're going to, if needed, you're going to be in bone grafting and gum surgeries. And then you're going to need an implant. And then you need to pay for the crown. Okay. So, and then a night guard. So a lot of things goes into implant, and most of the frustration that I see among my patients is lack of communication between the doctor and the dentist. Oh, I thought 2 days ago, I saw a patient in my clinic where they had an implant placed last year in one of the front tooth. The patient's mom saved enough money to place an implant, and they placed an implant. But I said, why are you not putting a crown on this tooth? And the mom was like, well, I told, it was $2,000 to get an implant. The doctor said it's $2,000 to get an implant. So I said, yeah, that's it. Okay. So I managed to save enough to get an implant. And he puts an implant, but then he said, well, that does not cover the crown. So the guy is now walking with no front tooth with an implant placed, but there is no crown because they just could not afford a crown. It's just a sad state, but again, the whole thing would have been avoided if the dentist would have told that, this is cost for placing the implant is this, cost of a crown is separate. And maybe if the dentist told the whole thing, the patient would not have preferred placing an implant in the first place, because now it is $2,000 for nothing. So I want all of you, at least who is listening, to know that cost of an implant, you should take all of this into account. And again, at least you should ask what are the things. If somebody says it's $3,500 for an implant, you should ask, what does it cover? Does it cover the implant? Any surgeries beforehand? Implants? Does it cover the crown? Does it cover, will I get a night guard? Whatever it may be, you should get, at least now what are the things that's going to go happen to you when you receive an implant. And when you talk to your dentist, make sure that you address all these concerns to him or her and get an idea, because you don't want to sign that line of consent without having clarity in your treatment process. And that's the whole point of me giving this lecture today, is just to educate you so that you can discuss these things with your dentist, so that there is less frustration and disappointment from either side.
Excellent.
And now I'm done.
Okay. Partha, excellent. I think Mr. Groover was asking that question. He left thinking you're not going to cover it.
Okay.
And that's the reason, actually, his question was the reason I said, let's go for it, Partha, because
no, I thought you were going to ask me that question, and then you asked Arvind's question. So I did.
No, I asked both. I actually put Mr. Groover, I said both of the questions, but I thought he's going to stay. But
oh, I'm just looking at my.
Yeah, there's a question on you.
Yeah. I don't
His
have the
question
chat.
came as for everyone, but that's okay. I hope
Did I
he
answer that question?
you answered his question, but the thing is, the gentleman left.
Okay.
But that's okay. I'll send it to. I'll put it on Facebook page. That shouldn't be a problem.
Okay.
Nagu, I have one last question from you. What are the top things causing enamel erosions? No Coke for you, Nagu.
That is one topic I skipped. So I keep
Yeah. Nagu, you want him to cover everything, right? Nagu has time today.
No, that's okay. If
No, I have these things, because
Yeah.
those are important
Partha
things.
has covered everything today. So
oh,
So this is the topic that I skipped, but basically this is becoming more and more prevalent, like how clenching and grinding the teeth is becoming more and more common. We are seeing, people having sensitive teeth and acid, erosions of their teeth. One of the common symptoms that patients are going to complain is their teeth are sensitive. It's not one tooth. It is like everything is sensitive. I just can't anything cold, because if it is a cavity, you can point to the tooth that is causing the problem. If it is a fracture or if it is something localized to one tooth, you can point to that. But if it is overall, if almost every tooth is affected, most of these cases of erosions affect a lot of teeth, not one or two. So in those cases, you're going to have sensitive teeth. So that is the example here, where you can see a shiny kind of structure. That is not how shiny usually things are. Okay, that is again shows that where is a wear. This is an example where there's a gum disease, and if the gums are exposed, you're going to have that. This is again overzealous. Somebody who is just brushing their teeth with too hard a toothbrush or too aggressively, they can actually wear away. If you look carefully here, you can see the enamel is still intact, because that is a very strong material. But what is happening is the gums have receded and it has exposed the dentin on the root. And the root dentin is not as strong or not as resistant to wear. So it wears off, leaving just enamel, because enamel is just too strong. So all of these can cause sensitive teeth. And this is probably what Nagu was asking. So how can I obtain relief? I think the main thing is the food. Almost all the food that we have drinking, eating and drinking is the pH of 5.5. That is the magic number. Okay, so any food that we eat or drink and ingest, if the pH is less than 5.5, it overwhelms our body's ability to neutralize it, overwhelms our saliva's ability to neutralize it. Saliva is important for keeping the teeth in right shape, and it can buffer to an extent. And if the pH falls below 5.5 and it stays for a while, then it is going to be there's not going to be enough capacity for our saliva to neutralize it. And it is again a very basic physical process. Enamel wear, erosions, and dentin erosions are very physical. It's almost like, as I said, if you take a science experiment, put enamel in acid, it's going to dissolve. If you put it in acid and then put it in baking soda, it's going to come back. It's not going to dissolve. So it is just the physics and chemistry that is happening. There's nothing biological in a sense that it happens inside the body. The only thing that contributes and adds on to this is the presence of bacteria, which also produces acids. So the food that we eat, almost everything, red wine is really bad things, or wine. Almost all fruit juices are acidic, extremely acidic, pH of around 3. Citrus fruits, any packaged fruits, any fresh fruits, if you look at this thing, there are hardly any fruits that are less acidic. That doesn't mean you should not eat fruits or drink fruit juice or whatever. My advice is always going to be, when you eat anything you want, you can eat chocolate, you can feast on donuts. I really don't care. The problem is people don't take care of it after the fact. We all know it is because of germs. And as long as we can starve the germs, we're going to be fine. So when you eat something sugary, make sure that you brush your teeth really well. You rinse your mouth 5 or 6 times with just plain water. Get all the refined sugars out of your mouth. And then you start using your toothpaste, your fluoride toothpaste, or things that if you protect yourself enough, you can feast on ice cream with no problems on your teeth. So pH is number one. Again, brushing your teeth, meticulous oral hygiene, good oral hygiene practices are always helpful, because this is cutting down on the bacterial contribution to erosions. And using a fluoride mouthwash like ACT will also reinforce the tooth. There are some sensitive, toothpaste for sensitive teeth, like Sensodyne is a good example. And I think it's also helpful to, if none of these work, then there's something biological that's happening. Maybe it's a cavity, maybe there's something. And again, extreme cases of erosions need to be dealt in a much more intensive way. I was trying to give a overall over-the-counter remedies that you have control over. But if this is your first aid kind of a thing, if your first aid doesn't help, then it means that you need to seek a professional consult and at least identify where things are going wrong.
Thanks, Partha.
Sure.
Thanks, Partha. Actually, I think we pretty much covered everything by now.
Yeah.
Any questions, guys? Okay, having said that, National Cancer Day is tomorrow, I guess, if I'm right. So our topic for next week, Latika is presenting on Saturday. Partha, no cherry farm for you on Saturday, so I'm sorry. I'm engaging the whole family now. So Latika is an RN. She's going to talk about cancer and stem cell transplant. And she's going to talk about that on Saturday at 4 o'clock. And also on Sunday, we're going to have Dr. Cliff Morris. He's a cardiologist. And he's going to talk about a lot of tips. In fact, he's going to talk about how to get off some medications. And basically, his topic is lifestyle medicine, the art of preventative cardiology. So basically, he's practicing in Richmond area, and we'll talk more about him on Saturday and Sunday. And so please tune in. It's very good informative sessions. And we will conclude everything the following week on Father's Day. So on that day, we're going to have two therapists talking about how to manage acute pain versus chronic, subacute pain. One of them is a sports therapist. One of them is a running specialist. They've already presented in this wellness series, but they're going to discuss, it's not going to be PowerPoint. It's going to be a discussion, and you can ask more questions if I miss anything. So it's going to be more spontaneous, trying to do that and see if we can be successful on that. So thank you all once again. Thank you for your time. Thank you for tuning in. Thank you, Partha, for all the great information. I think, starting from the first slide to the end, I know like you were thinking about time. The reason I wanted to go for it is like, it's a complete picture. So yeah,
I hope it was helpful.
Yes, definitely.
Good.
Thank you, guys. Thank you for logging in. Thank you all.